Hello, everyone. Welcome to another webinar on MRI. Today, we will be discussing interpreting MRI or magnetic resonance imaging in musculoskeletal practice, part 1, which essentially means the basics. Obviously, there are lots and lots of intricacies in studying and reading MRI, but at the end of the day, we are, health professionals. We are not radiologists. We don't need to undergo all sorts of details in an MRI. So essentially the very bone dry basic sequences that we are going to study together today should be more than enough to give you a good head start in terms of understanding and reading, and at the end drawing some conclusive evidence from MRI. Now please do remember, like yesterday, what we talked about on X-rays or radiographs, this MRI is not a first order diagnostic measure, right? Because X-ray or radiographs are the first order diagnostic measure. So don't think that you can blankly look at an MRI and see the, if there are any pathological abnormalities present or not. You have already done history taking. You have already done your evaluation like ROM, strength testing, or if it's a neuro case, the extensive neurological evaluation that you know how to do, you have already done that. For orthopedic cases, you have done your orthopedic special tests. So you have come to a 3 or 4 conclusion as to what the pathology or the diagnosis could be. And then obviously, if there is X-ray, you are also checking the X-ray. Then MRI comes into play. It's like 4th point down your evaluation screen. That's where you are seeing the MRI. So you, in your mind, you already have some kind of structure that will make you understand or help you understand, oh, this might be the problem or that might be the problem. So you already know what you are looking for. But please be aware, MRI is usually not done in, I'm obviously, since it's musculoskeletal practice, today's talk on MRI will focus only on orthopedic evaluation and diagnosis. So based off of that, you will not generally see MRI just because there is a fracture. If either a surgeon or a physician or an allied healthcare professional wants to know more in terms of what pathology is going on beyond bone, to differentiate between bone and soft tissues, or soft tissues and nerves, or neural structures and intervertebral disc, or what is going on between ligaments, tendons, and cartilage, then only you are going to ask or order for an MRI. Otherwise, you don't need an MRI at all, or a MRI at all right? So please bear that in mind. You just don't want an MRI for the purpose of just having a MRI in your hand. Makes sense? Right. So what's the learning objective for today? Hopefully by the end of this webinar, you will be able to explain a little bit of physics of the MRI, describe the medical indications, advantages, disadvantages, risks, and uses, explore a little bit of variations in types of MRI, a little bit of clinical decision making with MRI, when you want it, why do you want it, that kind of a thing. Obviously, this is very important bullet point. Recognize the different views and how you can read MRI in orthopedic cases. And at the end, we will discuss certain joints to identify normal versus pathological MRIs in musculoskeletal structures. So what to expect from today? So as I said, this is like a content of a book. So foundational knowledge, under foundational knowledge, we'll do a very brief, understanding about the physics. What is T1 weighted versus T2 weighted? Its application of MRI, indication, contraindications, risks, safety, and obviously how you can read MRI scans. At the end, we will discuss some of the major joints or segments in the orthopedic scenario or system which you need to see, have a look in terms of MRI. Now, before going to the next slide, when you look at an MRI, you usually don't see, a physician, surgeon, or you as PTs, you don't order MRI for wrist joint, for elbow joint, or for foot. You usually see MRIs for spine, mostly spine, probably 70% of the time in your clinic, hospital, or wherever, you always look MR of the spine to see if there is any disc bulge, disc herniation, and if there is any compromise in nervous system or neural structures. You also see in sometimes maybe 20% of your case, shoulder joint. So if there is any tear in the rotator cuff, if there is any bursitis under the bicipital tendon or above the subacromial region or inside the subacromial region above the supraspinatus tendon. So those are the things you usually see. You don't generally get along MRI of hip unless until you are looking for FAIs, femoroacetabular impingement, or any congenital dysplasia of the hip, or some kind of, let's say, knee joint MRI. Out of the blue, you will not come across a knee joint MRI. Knee joint MRIs are only required if a surgeon is doing total knee replacement or arthroplasty, or if a surgeon is asking for an arthroscopy of cruciates or menisci or collaterals. So these 3 or 4 ligaments and cartilages and non-contractile structures, if you want to look at, but particularly in the knee joint, then only you need MRI. But normally you don't expect MRI of the hip, knee, or even foot and ankle joint, right? So our talk will mostly cover the spine as a whole and the shoulder joint. I will touch very briefly on the hip joint, and understanding hip joint is very similar to understanding knee joint, because the same things or similar things that you see in the hip on MRI is the similar thing, relatively speaking, that you will come across in the knee joint too. So what is MRI? So in essence, MRI is actually produces extremely clear and detailed pictures. But pictures of what? Obviously, it will show you the entire systems of the body, but more so differentiating different structures in relation to each other. Please don't forget, as I told you earlier, always have a pen and paper. I will not read verbatim whatever is on the slide. I will tell you a story and picking key points, bullet points from the slide, and try to help you understand what MRI is. So what is important from what you want to know from MRI? Relationship between structures, the structural differentiation between a nerve or a disc, or a tendon versus a ligament versus soft tissue and a bone. So how are they different is what you want to look at in an MRI, in our MRI. So what is very, very important to know, and I have bolded in red, is it's not an ionizing radiation like X-ray or CT scan. So that's a great thing. So essentially you can ask for repeated MR scans in 1 calendar year or 1 year from the first MRI that individual has taken. So you don't need to worry about radiation going on, because it has no ionizing radiation. What it uses is nothing but magnetic resonance. It's a nuclear magnetic resonance that it takes place, that it's the scanner kind of takes in. Just a little bit of history. The first MRI scan of an animal, mouse or a rat, was published in 1973, and after 4 years in 1977, human studies were published under MR scans. And this is a, comparatively newer MRI that you can see, because it has thinned out a lot. The gantry where the patient goes, gantries where the patient kind of goes in or slides in, laying down in supine position, has also increased. There is a lot of light, and you can also hear music, okay, which actually is very good. Otherwise, you might feel claustrophobic if you are inside the MRI. All right, a little bit of physics, okay? So bear with me. You need to know how these scans are formed. Very, very briefly. As I said earlier, it's a magnetic resonance. So it's a magnetic resonance. Okay, great. But what is it resonating? What is it going like this? That's the hydrogen protons, not hydrogen molecules, but hydrogen protons, which is essentially H minus. Does that mean if I apply magnetic field, only the hydrogen protons will kind of move? No, nitrogen, oxygen, carbon atoms will also move. But the MR, magnetic resonance, has more affinity towards hydrogen. That's the reason the hydrogen protons wobble or spin randomly at a higher rate than carbon, oxygen, nitrogen, and other protons or ions that is present in the human body. So what happens after that? Okay, I can understand after a magnetic field is introduced, the hydrogen ions are kind of wobbling. Tuck, 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 tuck. This is how it is doing. And they align by itself. They become static. Fantastic. Now, when this radio pulse, radio frequency pulse is transmitted, it is actually wobbling, making the protons or hydrogen protons or ions basically wobble or move. When you take out that radio frequency, so radio frequency in, hydrogen ion wobble, radio frequency out, and the protons tries to relax and settle down. So relax from this stage to a more static state. So that is called relax right here. Please remember this word, because this is what you will come across under reports. When you are reading reports of an MRI, this is what you are going to come across. Relaxation period, T1 relaxation period, T2 relaxation period. So what is the better way of understanding this? Let's say your favorite team is playing cricket and your team is about to win, and so you are excited, you are like jumping in the sofa. It's a World Cup final and you are kind of jumping in the sofa. Okay, my team is going to win. So that is basically, you are a proton and you are like jumping up and down. And at the end, I'm sorry to break your heart, but let's say your favorite team kind of loses and you fall back, right? You kind of relax on the sofa and gets dejected. So that is essentially the relaxation of the hydrogen protons. So the hydrogen protons kind of relax. And what it does, after relaxation, it gives off radio frequency signal. And then what you do, you are irritated, you are frustrated, you are angry, you are like, you will obviously be angry towards your mother or wife or husband or children, and you will scold them. So that is essentially, you're giving off radio frequency. So that radio frequency, the energy that you are giving off, the hydrogen proton is giving off, is detected by that scanner. And what is the scanner? Here inside there are arrays of scanners, and I do have a picture and I will show you where the scanners are located. So that this radio frequency signal that is being emitted by the hydrogen protons, which are relaxing in the sofa, that is being detected by the scanner and then constructed as an image in the MRI scan. Okay, good. Now, things to remember. This is what you have to remember. Now, before I go on this slide, if you are starting to read MRI, let's say a patient comes in with an MRI and honestly you don't know what to do. After going over this webinar and when you again reread the content, don't jump into and see the report. Never see the report when you are starting to evaluate an MRI. When whatever you see in the MRI, write it down in a piece of paper, maybe 3 or 4 points, you write it down. Compare and contrast with the report of the MRI with what you have written. That's how you hone in the skill of understanding, knowing, and evaluating and coming to a conclusion as to what an MRI or what an MRI is saying. I always tried initially when I was starting to read an MRI. That is exactly how I started. So whatever I have seen, I might be wrong, I might be a little right, doesn't matter initially. You just write it down in a piece of paper. Then I saw the report of the MRI and compared what I had written. And if whatever is right, it's good. Whatever is not right, okay, I would better myself the next time. So that is how you hone in the skill of develop the skill of understanding and reading MRI. All right, good. So now coming back to things to remember about MRI. So this is exactly what you have to remember. T1 signal and T2 signal. There might be many different variations of MRI, but what we need as ortho specialists, orthopedic or musculoskeletal practice, we need T1 weighted images, T2 weighted images. But if you are a neuro specialist, there could be a whole different type of, weighted signals that you have to learn, and that I do it in advanced studies of MRI, but obviously not in the basics, because you need the understanding of the foundation to understand those special techniques. Okay, so what is T1? T1 relates to the speed of realignment with the magnetic field. That's fine. Do you need to know it? And honestly speaking, you don't need to know the physics of this. So it is essentially more speed the proton realigns, the greater the T1 signal. The faster the protons realign, that is the hydrogen ions realign, the greater the intensity of the T1 signal. So what is T2? I am jumping that bullet point. I will come back to it, the ones highlighted in red. So what is T2? T2 signals relate to the speed of proton spin dephasing. Dephasing meaning it is relaxing. The slower the dephasing, the greater the T2 signal. The slower it relaxes, the greater it emits those radio frequency signal taken up by the scanners. Got it? Now coming back to the red colored highlighted ones. T1 weighted images highlights fat. T2 weighted images highlight fluid. What do you mean by that? When you are looking at a T1 weighted image, the fat looks white in color. Write it down. Just remember these two and you'll be able to analyze rest of the stuff pretty easily. But you have to remember this basic principle. T1 weighted image, fat is white. T2 weighted image, water is white. T1 fat white, T2 water or fluid. Fluid is white in color. So how does it work? Look at the beautiful picture over here. Here are essentially your scanners are right over here. Here is basically the magnet which pushes the hydrogen protons and maintains their alignment. The radio frequency coils are right across. These radio frequency coils pushes the hydrogen ions to a wobbling state, and when that radio frequency is taken out, then the protons relax, and the energy radio frequency that it comes out or emits is actually captured by the scanner, and then the image is constructed from that. Okay, 3 things important for you in terms of understanding MRI machine: that magnets, radio frequency coil, and the scanner. That's it essentially. Basically, that's it. Okay, all right. So how is the MR image formed? Images are constructed when protons in different tissues return to equilibrium state. What is important for you to know? At different rates. Now, this is the clue to why MRI is so important to understand relationship between tissue structures, because it is the same proton that is what you are imaging, what you are seeing in the MRI scan. The differences in the shades of gray from black or dark to white or light gray is because they are coming at different rates of relaxation. I can relax faster, you probably relax a little slower. So the faster I relax, the more radio frequency I emit. The slower you relax, the slower radio frequency you emit. So that emission, the speed or velocity of emission, is taken up by a scanner at different time points, creating a picture at different time points. All right, fantastic. Now, I am not going to go over this, but what I am going to tell you right now is 5 variables affect this rate, and that is true: spin density, T1, T2, flow, spectral shift. If you ask me, do I need to know on this, all these things? Honestly, no, you don't need to. From musculoskeletal practice or from neuro practice, just basic understanding reading MRI, you don't need to understand. But just for your information, FYI, spin density is concentration. The higher the concentration of the nuclei in a tissue, especially muscles or fluid, you will be able to visualize that area better. Okay. T1, it's a relaxation time when it's in the longitudinal fashion. T2 in a transverse fashion, relaxation time. Do I need to know longitudinal wave, transverse wave? No. What I told you earlier, T1 highlights fat, fat is white. T2 highlights fluid or water, fluid or water is white. That is all you need to know till now. Okay. Now, flow. Flow means you have heard about MR angiography, MR venography, angiography for cardiac, basically arterial supply and cardiac health. You can do MR angiogram or MR venography, like for DVT, deep venous thrombosis, right? Any kind of venous occlusion, venous disease, you can do MRV, magnetic resonance venography. There is also magnetic resonance for CSF flow. CSF, cerebrospinal fluid flow. See, you can also do, flowmetry or flow check measurements through MR, and that basically shows blood flow, CSF flow, and various kind of flows. And probably you and I will not come across most of the time. If you are probably not working in a trauma center or acute, acute care center, ICUs and all, probably you will not come across flowmetry. Spectral shifts is another way usually done for brain, like in Alzheimer's disease, Parkinson's disease, even in MS, any central nervous system disease, they do spectral shifts to understand which areas of the brain are essentially affected. But from musculoskeletal standpoint, you will come across most of the time T1 and T2 weighted images. That's good. Now, just because there is only T1 and T2 doesn't mean that's end all be all, because under T1, T2, you can have different types of weighted images. You can have gadolinium enhanced, you can have fat suppressed, you can have sensitive flow attenuated, you can have some sensitive type of flowmetries also within T1, T2 weighted. T1, T2 weighted is the basic MR scan. Underneath, there are 5 or 6 variations in terms of, there is proton density type, there is diffuse weighted images also. So there are different types of weighted images. Again, for the purposes of today's basic webinar of MRI, T1 and T2 is what we are going to study and understand. So as we just talked about, T1 weighted differentiate, both T1 and T2 essentially differentiates between fat and water and in between other soft tissues. Water is darker, fat is brighter. As I said, brighter means white, darker is obviously blacker or darker shade of gray. Everything like X-ray, MR also is shades of gray, but you can certainly use dyes to create colors. And you can do flowmetry to introduce colors within the blood flow, like blue and red and shades of orange and other stuff you can certainly do. But again, since we are talking about basic ones, so it's shades of gray. Water is dark or black, fat is white or bright. Provides good gray matter, white matter contrast in the brain. So between T1 and T2, if you are into musculoskeletal or orthopedic practice only, you don't see neuro like me. I don't know neuro. I haven't done neuro in close to 2 decades. I haven't seen any patients. So I probably forgot the spelling of neurology now. Don't get, I'm kidding, but I'm just saying that I usually don't see, right? So for me, as a, as an osteopath and a chiropractor, it's not that I don't see T1, but for me, T2 weighted images are key. So when I read an X-ray, I jump into T2 weighted. So please note it down in your, wherever you are writing. So T2 weighted images is what you are going to look at if you are wanting to evaluate an orthopedic or musculoskeletal MRI. So what is T2 weighted? Fat obviously is, water is lighter and more brighter and whiter also, good for imaging edema. Now, let's talk a little bit on that. All right, I understand water will be white in a T2, fat is black or dark. So why am I understanding or trying to understand edema or fluid? Well, what is the purpose of MRI? MRI, as I said, is not the first thing you want to see. You will take your history, you will take your, medical history, you will take your evaluations, orthopedic evaluations. You will also see first order diagnostic tool, that is your X-ray. After that, if you feel there is beyond bone, there is some amount of anomaly, trauma, injury to soft tissues. It could be contractile soft tissue injury or non-contractile soft tissue injury. What do you mean by that? As the word suggests, contractile means muscles or skeletal muscles, and whereas non-contractile means your ligaments, tendons, cartilage, and other connective tissue. It also has fascia inbuilt in it, fascia, right? Or fascia, however you want to say. So fascia is anatomically non-contractile unit and functionally it's a contractile unit. Don't forget this. Anatomically, fascia is a non-contractile unit. Functionally, it's a contractile unit. Now, if you ask me, okay, sir, do you mean that the fascia can contract? No, it's structurally, it's a non-contractile. But since it is attached, stuck to muscles, when muscles contract, the fascia glides. So functionally, it is gliding. And that's the reason I am saying functionally, it is kind of contracting and stretching, relaxing and then contracting or coming close to each other. So why do I want to see T2 weighted images of our orthopedic conditions or musculoskeletal practice? Nothing but soft tissues differentiation. And if there is any trauma, there will be inflammation, inflammatory response, and you will have fluid, and fluid will be white in color. Okay, so doesn't matter if it's contractile unit or non-contractile unit, there will be some amount of inflammatory response in that local area, and you will be able to visualize that as a very bright white colored area in a T2 weighted image with soft tissue injury. Okay, so this is basically what I told you in a nutshell. Overall, 1 hour's worth of MRI scan. This is exactly what you are going to see in an MRI day in, day out in orthopedic. For most of the conditions, 80%, maybe 90% of your lifetime MR scans, this is exactly what you're going to see. T2 weighted images, where is the edema? If that is white in color, you know there is a pathology, and certainly you will evaluate further and diagnose it clinically. All right. So T1 and T2, let me give you an example. T1 weighted, normal Achilles tendon. T2 weighted, the Achilles tendon is torn, and you can see, how would I know? Obviously the connection between the tendon is lost, but more importantly, I have edema or fluid in here, which is white in color. All right, now in the MR, usually it is mentioned if it's T1 and T2. If it is not, don't get worried. But remember, T1, the bone is white in color. Look at the fat around the, just above the calcaneum, below the Achilles, or around the Achilles tendon, below the gastrosoleus muscle. Right over here, the fat layer is also very white. And you know very well that there is a bursa in there, right? Achilles bursitis, right? You know that. So the bursa has fluid, and the fluid over here and the fat over here will be white in color. So bone is white in color or lighter gray in color in T1. Bone is dark in color or black in color or dark gray in color in T2. This is an easy way to understand for you if you are looking at a T1 weighted or a T2 weighted image. Bone white, light gray, and very very bright, then it's T1. Bone dark, black, very dark gray, then you know it's a T2 weighted image. And then you see what you need to see in terms of, if it's a T1, you obviously see more fat layer. If it's a T2, obviously you know if there is an edema or a trauma, you will easily notice it because they will be white in color or bright in color. All right, good. Okay, fantastic. All right, now applications. I'm not going to go through the applications. You can easily gauge why you need MRI for which conditions: musculoskeletal problems, soft tissue bone pathology, sports injuries, spinal injuries, pelvic issues. Now, here I would like to tell you one thing. As I had told you earlier, 80% of the time the MR that will come across your eyes will probably be spine and your shoulder. But if you evaluate spine and you don't see a pelvis, that is a problem in the MR. You have to probably order a review or redo the MR with the pelvis, because it is extremely important as an osteopath and a chiropractor for me to understand what is going on in a lumbar spine in relation to sacrum and the innominate. If I don't see it under MRI, then I don't actually have a complete picture of what's going on in that mid, lumbar as well as the pelvic area. So when you are looking at the lumbar spine, make sure, write it down, make sure you also look at the pelvis. That includes the two innominates and the sacrum. Okay, lumbar spine, sacrum, two innominates is what you have to always look at. All right. Who can't have MRI or contraindications? And these are essentially the thing. Now, surgery in the last 8 weeks, it is, in the books that I have referred from is saying, but usually it's not done. It's not a contraindications or not a red flag. It could be a cautionary thing, because if the surgery has surgical prosthesis like TKR, THR, shoulder replacement, elbow, any metal that is inserted within the bone, maybe fracture, and a plate and screws, intramedullary nailing, whatever is done, anything that is foreign implant that is placed, then the patient will not be able to do an MRI. He or she can certainly go in for X-ray and CT scans, but not an MRI for the purposes, because it's a magnetic resonance. It will magnetize the metals. So that's the reason. So surgery last 8 weeks, if the surgery is not having any metal implants, then it's actually fine. Not a big deal, not a contraindication. All right. Safety risk, meaning when you are, I'm not sure how many actually experienced MR scans. So when you are inside an MRI, you actually have it sounds really loud, cut, like that, because the magnetic field and there is the coil that is generating radio frequency rotates. Radio frequency, it rotates because it takes scans like this, cut, and that is really loud, right? Because you are inside the MR scan. And that's the reason they give you headphones and music to hear. So you essentially have a very mild, you still can hear the sound, but it's not that much. But if someone has ear problems, if someone has sensitive ears, if someone has, middle ear infection, if someone has pus in the ear, it is better for them to prevent. Take medications, antibiotics, clear the ear out, ask the ENT to see and evaluate if the ear is fine, and then go in. So please be aware of if there is any ear infection, it is better not for him or her to go in and do an MR scan, because it can create more problems in the ear, especially vestibular, cochlear. Also, the second bullet point is kind of rare, but in certain cases it has been seen that because there is rapid switching start on and switching off of magnetic field, the peripheral nervous system can be hypersensitive and they can feel nervous stimulation or sometimes pain, especially in sciatica patients. Or someone who has gross neck, arthritic changes with radicularization in bilateral arm, really painful, they can also have peripheral nerve stimulation. So be aware. It's not a contraindication, but be aware of that. All right? Okay. It's just simple. Procedural issues. What do you mean by that? You have to stay motionless. When I went through an MR process, so I just closed my eyes. I was listening to some music and I lay motionless as much as possible and listen to music and just be there resting. So it is important to be motionless, because that if the patient has lots of motion, especially in central nervous system disorder, if there are tremors, tics, or involuntarily uncontrolled motion, they probably will not be able to do MRIs. Even individuals like adolescents who have CP or any other childbirth defects, congenital genetic defects, where they have to move automatically, involuntarily, they are also not suitable candidate for MRI, because it's not there is any contraindication, it's because they cannot lay motionless on the gantry, where the platform where the patient needs to lay down. And it takes time because it has to do, multiple parts in sequence is being taken. So it just takes time to switch between different scans and fields of view. That's basically it. All right. Now, we have talked about applications, but these common indications is focused mostly in orthopedic conditions. Obviously, ligament and tendon damage, soft tissue, that is muscular injuries, brain in. So I wanted to write spinal cord because it's musculoskeletal, and we are looking into disc bulge, disc herniation, and its relation with nervous. So it should be actually spinal cord injuries. Obviously, brain injuries is, but for the purposes of musculoskeletal practice, we don't look into it in that great of a detail, right? So it's obvious, isn't it? So it should be spinal cord injuries. And as I had said earlier, T2 is better for pathological conditions for orthopedic or musculoskeletal practice, because you want to basically visualize edema or inflammatory response, and that's basically it. And you can see it better because it will be white in color or brighter in color under T2 weighted images. All right. So MRI views. So views is basically 3 views, but this is for a brain, and since most of us will be looking into musculoskeletal or orthopedic, we will be probably only seeing transverse views and sagittal or sagittal view. We probably will not see any coronal view. In hip joint, it is likely that you will see a coronal view. In a shoulder joint, probably you will see a coronal view, but most of the time it is transverse view or a sagittal view. So you will see out of the 3, 2 most common views. For the spine, it's usually transverse sagittal. For the shoulder joint, it's transverse sagittal, in some cases coronal, especially if there is anterior shoulder pain, which is a non-conservatively, you are not able to treat it, then you can have to do a coronal slice to actually see what is going on, right? So, but overall picture, out of the 3 views, you actually need 2 views to understand what is going on. All right, so this is where it is very important for you. And I have tried to keep it as basic as possible for you to understand when you take up an MRI scan, how you are going to read it. Obviously, you have to familiarize with the view. How we are going to familiarize which one it is? On the top, usually on the top left corner, sometimes on the top right corner, you will see that they have actually put the entire, if it's a lumbar spine, low back, they will put a lumbar spine in there and some dotted lines. Based on those dotted lines, those are the slices that you are going to look at the bottom of the MR scan. So under the MR scan, there could be 16 slices, 32 slices, depending on how expensive the MR machine is or equipment is, the number of slices will be more, right? Again, there is 1.5 Tesla, 2.2 Tesla, 2.5 Tesla unit. Those are, the power of the magnetic field. More the power, the better the image quality and more vivid the response is in the image section, right? So if it's just 1.5 Tesla and 32 slices, for MR, that is good enough for orthopedic or musculoskeletal MR scans. But for brain, probably you need higher than 1.5 Tesla is better. More than 32 slices is actually better, especially for brain injury. when a surgeon wants to do some brain surgery for hematoma and stuff, they obviously need higher resolution, and they obviously might introduce dyes and stuff. All right. So coming back to, again, musculoskeletal practice, you will try to see what you are looking at based on either the top left or the top right, usually the top left, where they can show the lateral view or the transverse view. And then for sure you would know what you are looking at. Is it a transverse view or sagittal view? Usually for a spinal MRI, you won't see a coronal view because it doesn't usually show much, right? Make sense? Okay. Then obviously you identify it left and right. Now again, for a sagittal view or a coronal view, you should know which side is right or left. How you would know, even if there is no writing? Just remember, when you look at the scan like this, remember the scans are, the patient is this direction and the scans are circular. So they make this kind of cuts. When you look at the slice, you are looking at the patient from inferior to superior, from the foot end to the head end. So if your patient is supine, if you are standing in the inferior section or the foot section and looking at the patient, then you look at the foot first, then ankle, then knees, hips, shoulder, and the head. That is exactly how the slices are in the MR scan, from inferior to superior. So your left is actually patient's right, your right is actually patient's left. So please bear that in mind. You are looking the scan inferior to superior, foot towards the head, and then it will be easier for you. So it is exactly opposite of your anatomical position. Opposite of your anatomical position. Your left is scans patient's right, your right is scans or patient's left. Okay. Identify landmarks and the slice. How are you going to identify the slice? On the top left or the top right, you will see those dotted lines. Under the dotted lines, you would know which slice is actually you are looking at. It's pretty simple. Once you go in after 10 MRI, I am pretty much certain you will be able to analyze it really better from today and understanding what the problems are. Because the good part is you actually already have an idea of what to find. And what you are trying to find is, if it's there, like disc bulge hernia, or a hamstring tear, or a quadriceps sprain, or a patellar tendinitis, it is easy to find it out because there will be inflammation, right? And then certainly you will know if it's T1 or a T2 image, T2 weighted image. And this is what T1 and T2 will be, as I have told you. T2, water, white; T1, fat, white. As an orthopedic practitioner, or musculoskeletal practitioner, you will look at the T2 weighted first. That's it. All right. Again, advantages, risk compared to CT scans. So in terms of understanding the advantages and disadvantages, not with any other sorts of scans, but only with CT scans, well, no radiation, better resolution. Obviously, I love to do an MR over CT because of this reason. Only because the resolution is great when I am trying to compare and differentiate bone with soft tissues with nervous system, and between soft tissues, the different water characteristics or fluid characteristics. If I need to find out, I do an MR scan. And then obviously it gives more detailed information. Disadvantage, claustrophobia. Now I would like to share this. Many patients are claustrophobic. You may not know that honestly you are claustrophobic until and unless you experience that you are in a very, very narrow, like a den area, very dark room. Even if it's a well-lit room, one who is really claustrophobic, I'm messing the word today, claustrophobic, he really feels terrified, apprehensive, want to come out from that MR scan. Now, you can do a standing MR or an open gantry MR. I am not sure if it is present in where you live, but I know it is present in where I live. So you have standing MR, and open gantry. So essentially it's like a U shape, and the patient can basically go in and you can see it in everything in front. It is not enclosed. So, but there is a disadvantage. Open gantry or a standing MR scans, low resolution, and low resolution means very poor image quality. So but hopefully with time, with advancement in electronics and in information technology and softwares and hardwares, we'll get at one point, but right now it doesn't have good resolution. So my understanding thought process is, if I need to do an MR, it would be best if someone is doing it on a regular MR and not a standing one or an open gantry system. Okay, all right. It is obviously expensive and time taken, contrast agent. Now, contrast agents reactions, it can also be with CT scans, but obviously anything X-rays can also be done with contrast medium. You don't want to introduce radioactive dyes in your body. It probably will not have that much of effect once or twice in your lifetime, but if you keep on doing it, it is obviously not good at all. And rest of the stuff, implanted metal, prosthesis, if there is any inbuilt prosthesis, you cannot do MR. So please have this in mind. You can write it down. Contraindication, implanted metal, pacemakers and whatever whatnot, anything that is implanted, you cannot do. All right, we actually understand the basics of how to read the direct general MRI, in the sequence of reading an MRI. Now, specifically how to read spinal MRI. It obviously will be axial or sagittal. It always, for musculoskeletal practice, have a T1 and T2. But remember what I told you earlier, you always need to look for a T2 weighted image first, then go in for a T1 weighted and not vice versa. Okay? Then look for obviously bony alignment, a soft tissue integrity, if there is any tear or not. But if you are looking for a spinal MRI, I always go in, because bony alignment, I have already done that in the X-ray. My thought process is, if the disc is intact or not. That is the reason why I want to see the MR. Not just bony alignment. I certainly will do, but it is not my priority. It will be there in my mind, but not the first thing. It probably will be the third or fourth thing in my mind, but not the first thing in my mind. In my mind, I will take a look at the integrity of the disc and the relation of the disc with the spinal cord. These are the two most essential critical criteria that I will go and take a look first before going into check height of vertebral bodies, height of the disc, foraminal diameter, disc margins, bony alignment, soft tissue integrity. So this is how my thought process works. I will check again the disc health and relation to spinal cord and nerve roots. Then I will check the disc margins, height of vertebral bodies, bony alignment, foraminal diameter, and soft tissue integrity at the end. Okay. But if the individual had a trauma, like a road traffic accident, or maybe a suicide attempt, maybe a fall, right? An elderly individual just fell in the bathroom or slipped. So then I will again check for soft tissue integrity. Probably there is injury or tear or strain or sprain in the ligaments and other soft tissues. I will take a look at that. That will be my priority. So based on the complaints, I will prioritize how to read an MRI or a MRI based on the history and complaints of the patient. So now we are jumping to interpretation of the segments, right? So this is essentially the normal versus pathological cervical spine. And now you know that if the spinal cord and the bone is dark, then it is T1. If this fluid is white in color and the spinal cord is light gray, then you know it is T2 weighted. And as you can see beautifully that the spinal cord and the cerebrospinal fluid, which is essentially bathing the spinal cord. Look at the medulla oblongata and look at the cerebellum, beautiful cerebellum over here. But from the book I have taken, there are two things. It is saying it is normal. What are the two things that you think that you are seeing makes you feel maybe it is not perfectly normal, right? So for me, there could be lots and lots of interpretations. What you see, I may not see that initially. What I see, you may not see that initially. What I saw initially is, look at the lumbar lordosis. Can you see any proper normal curvature of the C-spine? I don't see any. What else do you see? Look at the huge amount of fat pad in the CT junction. CT junction, cervicothoracic C7T1 junction, lot of thick fat pad, which means this individual probably has a hump called the Dowager's hump. Dowager's hump right over here, as you have seen. Forward head posture, CT junction, there is a big hump, and that probably makes me feel that there is hypomobility of the CT junction because there is so much of fat pad. Normally, it will be a little more than above and below, but this is way too much in my opinion. Okay, again, in my opinion, it may not be in your opinion, because the interpretation is a little bit subjective, so that will be a variable. Again, from pathological standpoint, voila, and you can notice that there is a lot of disc bulge in here, 2 levels of disc bulge, which actually is compressing the spinal cord, right? As you can very easily notice. What is the other thing that you are noticing? Always look at these facet joints. Look at the facet joints. You are not able to distinguish the facet joints, which makes me feel that there is also for sure facet joint arthropathy. Now, is this again the first thing I'm looking at? No, I probably evaluate facets. I probably checked also in the X-ray. This is my second level of diagnostic measure. So by that time, this is a confirmatory process as to, okay, what I have seen, palpated, evaluated earlier, I am right on that. This is exactly what you are saying. Are you right or wrong? You can again honestly check this in an MR scan. This is exactly what you are noticing. All right. There are many other things, osteophytic lippings, as you can see, but those are best noticed essentially in your X-rays. But one thing I would like you to see, it is actually evident only under T2 spine in the intervertebral disc. So please write it down or note it down here. So here between intervertebral disc, we all know that there is nucleus pulposus within annulus fibrosus. Within annulus fibrosus rings, in the center you have gelatinous or gel-like material called nucleus pulposus. And since it's gel-like material, so obviously there will be water. And when there is water, it will be a little bit of a lighter shade, like this, like this, like this. See how light the shades are in T2. This is certainly T2 because the spinal, the CSF is bright white color, right? Now you know this is T2. But notice one thing. Look at the IV disc. The IV discs are dark, which makes me feel that the IV discs, please note it down. If the intervertebral discs are darker color, that means there is less or loss of signal intensity. You will see this noted by the radiologist in the report. There is loss of signal intensity or reduced signal intensity in this level. And that is exactly what I am noting. In these intervertebral discs, there is loss of signal intensity, because if there is water, there would be hydrogen ions or protons. And if there is hydrogen protons, it will be whitish or lighter gray in color, like over here where my mouse is hovering, and it will not be dark because there is no water or very, very minimal water, meaning the intervertebral disc is dehydrated. There is reduced water content within the disc that makes it less water, H2O, right? H2O, hydrogen and oxygen. So if there is less water, less hydrogen, so less hydrogen, less is white color, so it will be more dark, and that is exactly what I am noting. Very, very dark, which makes me feel that most of the C-spine IV discs or intervertebral discs are degenerated or in the process of degenerating. So a very, very critical point for you to note IV disc health of an IV disc. Loss of signal intensity or reduced signal intensity is darker color. Okay, good. And over here in the lumbar spine. Now, before we go on and discuss normal versus pathological lumbar spine, what are you noticing? These are horse's tail, nerve roots or horse's tail, right? Cauda equina, because you know that actually the spinal cord ends in lumbar 2, L2 vertebrae, right? Here you all is basically nerve fibers going in like a horse's tail, and this is normal, but this is not. Obviously you can see a huge disc bulge and actually not a bulge, it's an herniation. I can see a little bit of bulge as well as a dripping right over here. It's trickling down, so there is a little bit of disc herniation. What else you can see? Look at the beautiful horse's tail together, like women when they tie their long hair. But here look at the hairs, horse's tail. It is haphazard. The tails are like everywhere. Look at it. So there is nerve root compromise. So there are multiple things to note. There is nerve root compromise, so probably there will be radicular pain. There is disc herniation. Also, look at the intervertebral discs. White, kind of light gray in color. Darker color, darker shade, which means there is a loss or reduced signal intensity. That means this IV disc is degenerated because it is completely dehydrated. It is completely dehydrated as compared to this IV disc and this IV disc. Look at that, white or light gray, little bit of white and light gray, nothing. It's pretty dark. So that means the IV disc is degenerated. So disc herniation, nerve root compromise, radiculopathy, and degenerated disc. And degenerated disc or because there is dehydration of the discs. And then I can talk about many things, because if you see the lumbar vertebral body height, the disc height, they are again getting reduced. So you have to mention that. If you check the foraminal opening right over here and here, it's getting obliterated, or essentially the foraminal cavity or the diameter is also reducing. So those are the other things that you can also come across and visualize or analyze. Now, long story short, there is not much complexity in reading orthopedic or spinal MRs, right? Nerve root, discs, disc health, vertebral body height, intervertebral disc height, facets, foraminal diameter. So these are kind of the thing that you will look for in a lumbar spine MR. It can be your cervical spine or your lumbar spine or even thoracic spine. So these are the only variables or factors that you are going to look at and try to analyze. Okay, fantastic. Also, how to read shoulder and hip joint? Well, obviously it could be axial, sagittal, and coronal. So this is both. So mostly you will see axial, sagittal, but I have also have you in here the coronal slices, both of them. T1, T2, obviously. In shoulder, what you have to look for? Acromioclavicular joint integrity, right over here. Rotator cuff muscles, right under over here. And look at the supraspinatus muscle, right over here. Trapezius, as it is mentioned. You have your greater tuberosity over here. You have your supraspinatus tendon, very, very important area, because there is bursa, bursitis, or there will be tear. So you can, this area will be highlighted in a T2 weighted image. So be on a lookout in this area. Rotator cuff muscles and glenohumeral joint. For the hip, it is the femoral acetabular relationship. How is the acetabulum related to the femoral head? How is the femoral head angulated with the neck femur and the shaft femur and in relation to the acetabular cavity? head neck alignment. That is exactly what I just told you. How does the greater trochanter look? Gluteus medius, right? Gluteus medius minimus, that's where it inserts hip abductor. You have to check their insertion points. And neck shaft also angle. This is essentially for fracture avascular necrosis. If someone has avascular necrosis, you are going to look at it. But as I said earlier, hip joint, you probably will not come across. Mostly orthopedic surgeons want to look for if there is any avascular necrosis. You probably can see it, but post-surgery. Surgery has already been done, and then you can see that. Otherwise, you usually don't take a look at hip joint MRIs. All right, shoulder joint pathology. Now, remember, I am only showing you one slices of probably 16 or 32 slices that you will be actually seeing from anterior to posterior, lateral to medial, inferior to superior. 32 slices or 16 slices. I am only showing you one slice. So obviously matching the slices also matters a lot. That is why I told you, look at which slice you are looking at, either on the top left corner normally or sometimes top right corner. Always match which slice you are looking at. Otherwise, you'll be extremely confused. Okay? Very, very important. All right. Normal, which we have already talked about. Pathological. Look over here. What can you find? Very, very huge amount of signal densities, white areas, as you can notice, right? So this shows that there is actually this rotator cuff right over here, there is full thickness. This is the rotator cuff end. This is the insertion point right over here. This is the tear right over here where I am going. Full thickness RC or rotator cuff tear, and that is causing lot of inflammatory response on fluid, which is not only accumulated in the area, localized area, but also is pervading the joint, glenohumeral joint in front and also within the joint right over here. So the entire area has fluid. That's why it's so bright and white, because there is this rotator cuff over here, or supraspinatus, to be more exact or accurate. There is a full thickness tear in here. There is obviously, as you can see, there is tendon perforations because white fluids is in between the tendon, and that's the reason there is increased signal intensity of the tendonal area right over here. The intensity should be less or darker in color, but this is very white in color. That's the reason you have lots of fluid in there. So that's basically it. You just have a rotator cuff tendon, tear, nothing else in there. Again, am I looking for a fracture or other anomaly, bony anomaly? No, I am only looking for soft tissue issues, tendon or muscles or ligaments or cartilage issues. Wherever soft tissues, it could be contractile or non-contractile. Those are the structures I am looking at. So a rotator cuff tear. Again, normal or pathological. Now, this again, you will not come across this. Probably surgeons will take a look. Normal, as you can see, is obviously everything edge looks okay. Here, look at this darker area. This is basically, there is neck femur fracture. So probably that surgeon wanted, before surgery, wanted to analyze better the soft tissue relation, the adductor muscle relationship to the fracture side, to understand the technicalities of surgery. That's why probably he or she took this kind of a coronal axis or plane MR arthrogram to basically check what is going on. Other than that, look at the beautiful acetabulum, which is really thick. There is no much avascular necrosis problems over here. There is that fovea centralis. This depression right over here is normal. It's called fovea centralis right over here, right? And if you remember, there are 3 arteries supplying the head of the femur. If one artery is ruptured, there is 33.33% blood supply is lost, because there are only 2 other arteries. So 66.66% of blood supply will be then possible or viable for the femoral head. As a result, in elderly adults, if out of the 3, one artery is cut, traumatic, injured, then there is a higher likelihood of avascular necrosis. All right. So this is again, there is no soft tissue injury. I wanted to give you this idea because yes, people do, or surgeons do MR scans for bone fractures, but you will not come across them. It is only for surgical technicalities for them to understand the surgical viewpoint. All right, lastly, take home message. So when you come back to this video later on, probably on YouTube, what you are going to look for, things to look for within an MR scan. When do you want T1 versus when do you need T2 weighted images? Obviously, contraindication, safety risk. Remember, if someone is claustrophobic, probably it's a no-no. Or if someone has metal prosthesis inside the body, then no MR, it would be an X-ray or a CT scan. Obviously, important is how to read, and then certainly go in with normal and pathological MR scans. Again, lastly, before we end that, a basic understanding of MRI in musculoskeletal practice webinar for today. When you as a allied healthcare professional, you will come across mostly spine. If you are seeing spine, then you actually go in to check the intervertebral disc integrity first. If you are seeing for the shoulder joint, the second most important MR scan, check for the rotator cuff integrity. And remember this first thing, MR scan is not the very first thing that you are going to look. After history, evaluation, X-ray, that's after that you are going to see MR scan. So already in your mind, you have a clue as to what you are going to look at. Never forget that, okay? All right, with this is my contact information, and probably most of you know, I would honestly strongly urge you and recommend you to subscribe to the YouTube channel, because there are really good content in there. It is not just me talking. I know there is another individual who are very good from New York, who have given diet and nutrition in injury recovery. If you have not seen that video, I would strongly encourage you to see that video. Anyway, this is my contact information. You please feel free to either share or contact me for anything related to musculoskeletal orthopedic practice. But for you, as I said, I'm an osteopath and a chiropractor. I see different types of clients or patients than normally what you do in PT practice. All right, so we will start the question and answer session right now, and then we will go from there. So I will stop sharing, and then probably I'll stop recording. Thank you, everyone. The chat box is open for you to ask me questions. Have a good rest of